Discuss the concept of patient-centered care and how it differs from traditional medical models. What are the key components of patient-centered care, and how can healthcare providers implement these principles in practice? Answer: patient-centered care (PCC) is a model that emphasizes the patient's preferences, needs, and values in clinical decision-making. Unlike traditional models, which often prioritize the provider's expertise or institutional protocols, PCC fosters a collaborative environment where patients actively participate in their care. Key components of PCC include respect for patient preferences, involving patients in decisions about their treatment options, coordination and integration of care, ensuring that care is seamless and that providers communicate effectively with one another, information and education, providing patients with clear, comprehensive information regarding their conditions and treatment options, emotional support, addressing patients' psychological needs and providing reassurance. Healthcare providers can implement these principles by conducting thorough patient interviews to understand their concerns and preferences, creating interdisciplinary teams to ensure holistic care delivery, utilizing decision aids to facilitate shared decision-making, providing access to resources and support systems. By adopting PCC, healthcare providers can improve patient satisfaction, adherence to treatment plans, and overall health outcomes. Explain the role of evidence-based practice in clinical decision-making. How does a clinician balance individual patient preferences with the best available evidence? Answer: evidence-based practice involves integrating the best available research evidence with clinical expertise and patient values to guide healthcare decisions. The EBP process typically includes formulating a clinical question using the PICO, Patient Intervention Comparison Outcome Framework, searching for the best evidence, identifying relevant studies and systematic reviews, praising the evidence, evaluating the quality and applicability of the research, integrating evidence with clinical expertise, considering the clinician's knowledge and experience, considering patient preferences, engaging the patient in discussions about their values and choices. To balance individual patient preferences with the best available evidence, a clinician should facilitate open discussions with patients about their values, goals, and concerns, present evidence in an understandable way, highlighting the relevance to the patient's situation, collaborate with patients to develop a treatment plan that aligns with both evidence and their preferences. Ultimately, the goal of the BP is to enhance the quality of care while respecting patients' autonomy. A 58-year-old female patient presents with fatigue, weight gain, and cold intolerance. She has a history of hypertension and hyperlipidemia. Describe the clinical reasoning process you would use to arrive at a differential diagnosis for her symptoms. Answer: in this scenario, the clinical reasoning process involves several steps. Gathering information. Start with a thorough history and physical examination. Note additional symptoms like skin changes, hair loss, or menstrual irregularities, and document any medication history. Identifying key symptoms. Fatigue, weight gain, and cold intolerance suggest potential endocrine disorders. The patient's age and gender are also significant. Formulating a differential diagnosis. Common considerations may include hypothyroidism, most likely given the symptoms. Depression, weight gain, and fatigue can indicate this. Chronic fatigue syndrome anemia also causes fatigue heart failure, especially with hypertension history. Prioritizing the differential. Given the strong clinical suspicion of hypothyroidism, it should be at the top of the list. Planning further evaluation. Order laboratory tests including TSH freed and complete blood count to confirm the diagnosis. Discuss the importance of preventive care in the management of chronic diseases. How should healthcare providers approach preventive care in high-risk populations? Answer: preventive care is crucial in managing chronic diseases as it helps identify risk factors early and promotes healthy lifestyle changes that can prevent disease onset. The importance of preventive care includes early detection, regular screenings e.g. blood pressure, cholesterol, and diabetes can identify conditions before they progress. Health education, informing patients about lifestyle modifications such as diet and exercise can reduce risks. Immunizations, ensuring that patients receive vaccinations to prevent infectious diseases that can complicate chronic conditions. Healthcare providers should approach preventive care in high-risk populations by conducting thorough risk assessments, considering social determinants of health, developing tailored interventions that consider cultural and socioeconomic factors, encouraging regular follow-ups to monitor health changes and adherence to preventive measures, collaborating with community resources to provide comprehensive support e.g. nutrition programs, exercise classes, In conducting a patient history, what techniques can enhance the quality of the information obtained, and why is this information critical for clinical decision-making? Answer: effective patient history taking is fundamental to accurate diagnosis and management. Techniques to enhance history taking include open-ended questions, starting with broad questions e.g., can you tell me about your symptoms? Encourages patients to provide detailed responses. Active listening, demonstrating engagement through nodding and paraphrasing helps patients feel heard and valued, promoting more openness. Clarifying and probing. If initial answers are vague, clinicians should ask follow-up questions to delve deeper e.g., can you describe the pain further? Empathy and rapport building. Establishing a trusting relationship can lead to more honest and comprehensive disclosures from patients. This information is critical because it guides the differential diagnosis and informs subsequent testing and management strategies, identifies psychosocial factors that may affect treatment adherence and outcomes, enables personalized care, aligning treatment plans with the patient's lifestyle and preferences. A 45-year-old male presents with chest pain that radiates to his left arm and shortness of breath. He has a family history of coronary artery disease. What differential diagnoses should be considered, and how would you prioritize them based on this presentation? Answer: the presenting symptoms of chest pain, radiation to the left arm, and shortness of breath, combined with the patient's family history, raise concern for several conditions. Key differential diagnoses include myocardial infarction. The classic presentation and risk factors make this the most urgent diagnosis to rule out angina pectoris. Stable or unstable angina can present similarly, particularly with exertion. Pulmonary embolism. This should be considered, especially if there are risk factors such as recent surgery, long travel, or immobilization. Aortic dissection, a rare but critical condition characterized by severe chest pain with potential radiation. Gastroesophageal reflux disease. While less likely given the severity of symptoms, it can mimic cardiac pain. Pneumonia or pneumothorax could be possible if there are additional respiratory symptoms. Prioritization should be as follows: myocardial infarction, immediate evaluation, troponins is warranted. Pulmonary embolism, if there are signs such as hypoxia or tachycardia. Aortic dissection, if the pain is abrupt and severe. Angina pectoris, consider if initial tests for MI are negative. Gastroesophageal reflux disease, consider after cardiac causes are ruled out. This structured approach ensures prompt identification and management of life-threatening conditions. Describe how quality improvement principles can be applied in a clinical setting to enhance patient outcomes. Provide an example of a QI initiative and its potential impact on patient care. Answer: quality improvement principles focus on systematic efforts to enhance healthcare processes and outcomes. Key elements include data-driven decision-making, utilizing data to identify areas for improvement and measure progress. Patient-centered approaches, engaging patients in feedback processes to ensure services meet their needs. Interdisciplinary collaboration, fostering teamwork across various disciplines to implement changes effectively. An example of the QI initiative is the implementation of a standardized protocol for the management of patients with sepsis. Identification, utilizing early warning systems based on vital signs to flag potential sepsis cases. Education and training, providing staff with training on sepsis recognition and management. Follow-up, regularly reviewing case outcomes and adjusting protocols based on findings. The potential impact includes reduced mortality rates due to earlier recognition and treatment of sepsis, improved adherence to evidence-based guidelines, enhanced patient satisfaction through quicker interventions and better communication. By embedding QI principles into daily practice, healthcare providers can continuously enhance patient care quality and outcomes. A 65-year-old female patient with a history of type 2 diabetes presents with poorly controlled blood sugar levels. Outline a comprehensive treatment plan considering lifestyle, pharmacological interventions, and patient education. Answer: a comprehensive treatment plan for a patient with poorly controlled type 2 diabetes should encompass several components: lifestyle modifications, diet. Implement a balanced diet emphasizing whole grains, lean proteins, healthy fats, and plenty of fruits and vegetables. A registered dietitian can assist in meal planning. Physical activity, encourage at least 150 minutes of moderate intensity aerobic exercise weekly combined with strength training twice a week. Pharmacological interventions, metformin as the first-line medication for type 2 diabetes. Unless contraindicated, consider adding additional agents depending on individual circumstances. Consider adding GLP-1 receptor agonists Liraglutide for weight loss and cardiovascular benefits. LT inhibitors. Empagliflozin for renal protection and weight loss. Monitor blood sugar levels. Regularly review the patient's home blood glucose records to adjust medications as needed. Patient education. Diabetes self-management education. Teach the patient about carbohydrate counting, insulin administration if applicable, and recognizing signs of and hypoglycemia. Regular follow-ups. Schedule quarterly visits to assess glycemic control, HbAC levels, and modify the treatment plan as necessary. Emotional support. Discuss potential psychological impacts and refer to mental health services if needed. This multifaceted approach addresses the complexities of diabetes management, promoting optimal patient outcomes. Discuss the significance of follow-up appointments in chronic disease management. How should healthcare providers structure these appointments to maximize effectiveness? Answer: follow-up appointments are critical in chronic disease management for several reasons. Monitoring disease progression. Regular evaluations help assess the effectiveness of treatment strategies and adjust them as needed. Identifying complications early. Continuous monitoring allows for the timely detection of potential complications, minimizing their impact. Encouraging adherence to treatment. Follow-ups provide opportunities to reinforce treatment plans, encourage medication adherence, and discuss barriers to compliance. Healthcare providers can structure follow-up appointments as follows. Pre-appointment preparation. Review the patient's history and any changes in symptoms since the last visit. Standardized assessment tools. Utilize validated tools to assess disease-specific outcomes. Questionnaires for diabetes management. Goal setting. Collaboratively set specific, measurable, achievable, relevant, and time-bound SMART goals for the upcoming period. Comprehensive review. Discuss medication regimens, potential side effects, lifestyle modifications, and psychosocial factors. Documentation and coordination. Ensure thorough documentation of findings and communicate with other healthcare providers involved in the patient's care. By adopting a structured approach, providers can enhance the quality of follow-up care, ultimately improving patient outcomes. What are the key components of a focused physical examination in a patient presenting with neurological symptoms? Explain how the findings guide the differential diagnosis. Answer: a focused physical examination for a patient with neurological symptoms should include neurological assessment, mental status examination, assess orientation, memory, language, and higher cognitive functions. Cranial nerve examination. Test each of the 12 cranial nerves for abnormalities, e.g. visual field defects, facial symmetry, motor function. Evaluate strength, tone, and coordination through specific tests, e.g. finger-to-nose test, sensory function. Assess light touch, pain, temperature, and proprioception in all limbs. Reflexes. Test deep tendon reflexes, e.g. biceps, triceps, patella, Achilles, and assess for any pathological reflexes, e.g. Babinski sign. Gait and balance. Observe the patient walking, performing heel-to-toe walking and balancing on one leg to assess coordination and balance. The findings from these components guide differential diagnosis significantly. Weakness and atrophy suggest peripheral nerve involvement, e.g. neuropathy or central nervous system lesions, e.g. stroke reflex abnormalities. Hyperreflexia may indicate upper motor neuron lesions, while hyporeflexia suggests lower motor neuron lesions. Cognitive changes may indicate dementia, delirium, or other neurodegenerative conditions. Cranial nerve deficits. Localized potential lesions, e.g. brainstem or cortical injuries. The focused physical examination thus provides critical insights into the underlying neurological pathology, guiding further diagnostic testing and management. A 55-year-old male patient presents with new-onset atrial fibrillation and complaints of palpitations. He has a history of hypertension and hyperlipidemia. What immediate management should be initiated for this patient, and what are the considerations for anticoagulation in this context? Answer: in the immediate management of atrial fibrillation, the first step is to assess the patient's hemodynamic stability. If the patient is stable, rate control can be achieved with beta blockers or calcium channel blockers, such as metoprolol or diltiazem. The next consideration is anticoagulation to prevent thromboembolic events, especially given the patient's risk factors, age, hypertension, and hyperlipidemia. The Chans-Vasc score should be calculated to assess the need for anticoagulation. Congestive heart failure. 1 point hypertension. 1 point age 75 years. 2 points diabetes mellitus. 1 point Stroke thromboembolism. 2 points vascular disease. 1 point age 65. 74 years. 1 point female sex. 1 point. In this case, with a Chad's-Vasc score of at least 2, anticoagulation, e.g. warfarin or direct oral anticoagulants like apixaban or rivaroxaban is indicated unless contraindicated if the patient has a high risk of bleeding or if the atrial fibrillation is determined to be paroxysmal. Anticoagulation management may differ. 30-year-old female presents to the emergency department with fever, chills, and a rash on her trunk that has spread to her extremities. She reports recent travel to an endemic region for dengue fever. What diagnostic tests should be ordered, and what are the management strategies for suspected dengue fever? Answer: in this scenario, the patient likely has dengue fever, particularly given her recent travel history. Diagnostic tests to order include complete blood count (CBC). This can show thrombocytopenia and leukopenia. Dengue NS antigen test. This is useful for early diagnosis. Dengue IM and IgG antibody tests. These are used to confirm past infections or to assess acute infection. Management strategies for dengue fever primarily focus on supportive care, as there is no specific antiviral treatment. This includes hydration, oral or intravenous fluids to prevent dehydration, analgesics. Acetaminophen is preferred for pain and fever, as NSAIDs can increase bleeding risk. Monitoring for warning signs of severe dengue, which include abdominal pain, persistent vomiting, and signs of bleeding. Patients should be advised to avoid mosquito exposure to prevent transmission. A 4-year-old boy is brought to the emergency department after experiencing a seizure. The mother reports that he had a fever of 102 deg, 38.9 deg for the last 3 days. What is the most likely diagnosis, and what are the management steps? Answer: the child likely has a simple febrile seizure, which is common in children aged 6 months to 5 years, typically associated with fever. Management steps include stabilization. Ensure the child is in a safe position during the seizure and monitor airway, breathing, and circulation. Antipyretics. Administer acetaminophen or ibuprofen to manage fever. Observation: most simple febrile seizures are self-limiting, and hospitalization is generally not required unless the seizure lasts longer than 5 minutes or there are other concerning signs, e.g. focal features, recurrent seizures. Education. Parents should be educated about the benign nature of simple febrile seizures and reassured about the child's prognosis. A 40-year-old woman presents with weight gain, fatigue, and new-onset hypertension. Physical examination reveals a rounded face and striae on the abdomen. Laboratory tests show elevated cortisol levels. What is the most likely diagnosis, and what is the next step in management? Answer: the symptoms and signs presented are suggestive of Cushing's syndrome characterized by excess cortisol. The next step in management is to confirm the diagnosis through 24-hour urinary free cortisol test to measure cortisol production, low-dose dexamethasone suppression test to assess the negative feedback mechanism of cortisol. Once Cushing's syndrome is confirmed, further evaluation is necessary to determine the etiology, e.g. pituitary adenoma, adrenal tumor, ectopic ACTH secretion. Treatment options may include surgical resection of the source of excess cortisol, medical management with steroidogenesis inhibitors like ketoconazole, or radiation therapy if indicated. Mr. Anderson, a 62-year-old male with a history of smoking and COPD, presents with worsening dyspnea and productive cough. On examination, he is noted to have wheezing and decreased breath sounds. A chest X-ray shows hyperinflation of the lungs. What would be the most appropriate initial management for Mr. Anderson, and what guidelines should be considered for the treatment of COPD exacerbations? Answer: for Mr. Anderson, the initial management of his COPD exacerbation should include bronchodilator therapy. Administer short-acting bronchodilators, e.g. albuterol via nebulizer or metered-dose inhaler MDI for immediate relief of symptoms. Corticosteroids. Systemic corticosteroids, e.g. prednisone, should be started to reduce airway inflammation, with guidelines recommending a short course, usually 5-7 days. Antibiotics. Consider if there is an increase in sputum purulence or if the patient requires hospitalization, particularly given the productive cough. The Global Initiative for Chronic Obstructive Lung Disease GOLD guidelines recommend these steps for the management of COPD exacerbations, emphasizing the importance of reassessment after initial treatment to determine the need for hospitalization or further interventions. A 45-year-old female presents with recurrent headaches characterized by unilateral throbbing pain accompanied by nausea and photophobia. She reports that the headaches often resolve after several hours but have become more frequent over the past month. What is the most likely diagnosis, and what pharmacological treatments should be considered for both acute and preventive management? Answer: The patient likely has migraine headaches. The acute management involves triptans e.g. sumatriptan. These are first-line agents for acute migraine attacks as they are effective in alleviating headache pain. NSAIDs or acetaminophen can also be used for mild to moderate attacks. For preventive management, particularly given the increase in frequency, consider beta blockers e.g. propranolol. These are often used for migraine prophylaxis. Antidepressants e.g. amitriptyline can also be effective for prevention. Antipileptic drugs e.g. topiramate, another option for migraine prevention. Patient education on lifestyle modifications e.g. regular sleep patterns. Hydration should also be emphasized. A 70-year-old man is scheduled for elective surgery but has a history of coronary artery disease and presents with a recent episode of unstable angina. What preoperative assessment is crucial in this case, and what modifications to the surgical plan might be necessary? Answer: given the patient's unstable angina and history of coronary artery disease, a comprehensive preoperative cardiac assessment is crucial. This includes cardiac risk assessment. Utilize the American College of Cardiology, American Heart Association, ACARTA guidelines for preoperative cardiac evaluation. Non-invasive testing, depending on the results of the risk assessment. A dobutamine stress echocardiogram or nuclear stress test may be indicated to assess cardiac function. Modifications to the surgical plan may include delay of elective surgery. If cardiac evaluation reveals significant ischemia or high risk, postponing the surgery until the cardiac condition is stabilized is appropriate. Consultation with cardiology. Involvement of cardiology for optimization before surgery, which may include adjustment of medications e.g. antiplatelet therapy or consideration for coronary intervention. A 50-year-old female presents with dysphagia, weight loss, and a history of gastroesophageal reflux disease (GERD. An endoscopy reveals a mass at the gastroesophageal junction. What is the most likely diagnosis and what is the recommended management approach? Answer: the clinical presentation is highly suggestive of esophageal adenocarcinoma, especially given the history of GERD. The management approach should include tissue diagnosis, endoscopic biopsy of the mass to confirm malignancy, staging, CT scan of the chest and abdomen to assess the extent of disease and evaluate for metastases. Management depends on staging. For early-stage disease, surgical resection, esophagectomy may be curative. For more advanced disease, a multidisciplinary approach including chemotherapy and radiation therapy may be indicated. Follow the National Comprehensive Cancer Network (NCN) guidelines for specific treatment recommendations based on staging and individual patient factors. A 35-year-old male presents with persistent feelings of sadness, hopelessness, and an inability to enjoy previously pleasurable activities. He reports difficulty sleeping and significant weight loss over the past 2 months. What diagnostic criteria should be applied, and what are the first-line treatment options for this condition? Answer: the patient likely meets the criteria for major depressive disorder (MDD) as outlined in the DSM-5. Key diagnostic criteria include presence of at least 5 depressive symptoms e.g. depressed mood, anhedonia, weight change, sleep disturbances lasting for at least 2 weeks. Symptoms must cause clinically significant distress or impairment in social, occupational, or other areas of functioning. First-line treatment options include selective serotonin reuptake inhibitors (SRIs) e.g. sertraline, escitalopram. These are the most commonly prescribed and effective pharmacological treatments for MDD. Psychotherapy, cognitive behavioral therapy (CBT) is effective especially in conjunction with pharmacotherapy. Monitoring for treatment response and potential side effects is crucial in the initial treatment phase. A 60-year-old male with a history of diabetes and hypertension presents with bilateral lower extremity edema, proteinuria, and elevated creatinine levels. What condition is most likely responsible for these findings, and what management strategies should be employed? Answer: the patient likely has diabetic nephropathy, a common complication of diabetes characterized by progressive kidney damage. Key findings include proteinuria, often a sign of glomerular damage. Elevated creatinine indicates reduced renal function. Management strategies should focus on controlling blood glucose levels and managing hypertension. Specific recommendations include angiotensin-converting enzyme ACE inhibitors e.g. lisinopril. These can reduce proteinuria and protect kidney function in diabetic patients. Tight glycemic control. Aim for an HbAC target of less than 7% to minimize the progression of nephropathy. Lifestyle modifications. such as a low-sodium diet, regular exercise, and weight management to address hypertension and improve overall health. Regular follow-up and monitoring of kidney function and proteinuria levels are essential in managing diabetic nephropathy. A clinical researcher is planning a study to investigate the relationship between a new dietary supplement and the reduction of blood pressure in adults with hypertension. The study involves following a group of 200 individuals with hypertension, half of whom will receive the supplement and half of whom will receive a placebo. Blood pressure will be measured every 3 months over a 2-year period. What type of study design is being employed in this research, and what are the potential strengths and weaknesses of this approach? Answer: the study described as a randomized controlled trial (RET). This is an interventional study design where participants are randomly allocated to either the treatment group or the control group. Strengths: randomization minimizes selection bias, ensuring that the groups are comparable. The use of a control group placebo helps to isolate the effect of the intervention. The longitudinal follow-up over time allows for causal inferences about the supplement's effect on blood pressure. Weaknesses: compliance issues may arise, with participants dropping out or not adhering to the intervention. It may be expensive and time-consuming. There is always a risk of confounding factors, though randomization helps reduce this risk. The design is commonly used for evaluating the efficacy and safety of interventions, and in this case it will provide strong evidence of the supplement's impact on blood pressure. Which pharmacokinetic process describes the movement of a drug from its site of administration into the bloodstream, and what factors affect this process? Answer: the process is called absorption. It refers to how a drug moves from its administration site, e.g. oral, intravenous, intramuscular, into the systemic circulation. Several factors affect absorption, including route of administration. Drugs given intravenously bypass absorption as they are directly introduced into the bloodstream, while oral drugs must pass through the digestive system. Solubility: lipid-soluble drugs pass more easily through cell membranes compared to water-soluble drugs. pH and ionization: drugs are absorbed differently based on their pK and the pH of the environment, e.g. acidic drugs are absorbed better in the stomach. Blood flow to the absorption site: increased blood flow enhances absorption. Surface area available for absorption: larger surface areas, e.g. the small intestine, allow for greater absorption. Understanding these factors is critical for predicting how quickly and effectively a drug will enter the bloodstream and exert its effect. Dr. Sarah is managing a 35-year-old woman, Jennifer, who presents with fatigue, joint pain, and a facial rash that worsens with sun exposure. Laboratory results show a positive anti-nuclear antibody on a test and elevated anti-DNA levels. Jennifer is concerned about her prognosis and asks whether this condition is curable. What diagnosis is most likely, and how should Dr. Sarah counsel Jennifer about the nature of her disease and long-term management? Answer: Jennifer's clinical presentation and lab results are consistent with systemic lupus erythematosus, SLE, an autoimmune disease. In SLE, the immune system attacks the body's own tissues, leading to inflammation and damage to various organs, including the skin, joints, kidneys, and nervous system. Prognosis: SLE is a chronic, lifelong condition with no cure. However, its course can vary from mild to life-threatening depending on the organs affected. The disease often follows a relapsing remitting course, with periods of flare-ups and remission management. Dr. Sarah should explain that while there is no cure for SLE, early and aggressive treatment can control symptoms, reduce flare-ups, and prevent organ damage. Immunosuppressive medications, e.g. corticosteroids, hydroxychloroquine, are often prescribed to manage the condition. Regular monitoring and lifestyle adjustments, such as avoiding sun exposure, are essential. Educating the patient about the importance of medication adherence and routine follow-ups is crucial to managing the disease effectively. A 62-year-old male patient on warfarin for atrial fibrillation is prescribed trimethoprim sulfamethoxazole for a urinary tract infection. The patient presents with increased bleeding tendencies after starting the antibiotic. Explain the pharmacological interaction between warfarin and trimethoprim sulfamethoxazole and the mechanisms leading to this adverse effect. Answer: trimethoprim sulfamethoxazole interacts with warfarin by inhibiting cytochrome P enzymes, specifically Syk, which is responsible for metabolizing warfarin. By inhibiting this enzyme, trimethoprim sulfamethoxazole reduces the metabolism of warfarin, leading to increased warfarin levels in the blood. This results in prolonged prothrombin time, PT, an international normalized ratio in a, heightening the risk of bleeding. Mechanism of interaction: warfarin is an anticoagulant that inhibits the synthesis of vitamin K-dependent clotting factors. Trimethoprim sulfamethoxazole inhibits warfarin metabolism, causing an increase in its bioavailability. This leads to excessive anticoagulant effects and subsequent bleeding complications. Management. The warfarin dose may need to be adjusted, or an alternative antibiotic should be considered. Regular iron monitoring is essential during the course of the antibiotic to prevent serious bleeding events. Explain how chronic hypertension leads to left ventricular hypertrophy (LVH) and describe the potential complications associated with this condition. Answer. Chronic hypertension increases the afterload on the heart, meaning the left ventricle must work harder to pump blood against the elevated pressure in the systemic circulation. Over time, this increased workload causes the left ventricular myocardium to thicken, leading to left ventricular hypertrophy (LVH). Mechanism. Increased afterload from hypertension leads to greater resistance during ventricular contraction. To overcome this resistance, the ventricular wall thickens, a compensatory mechanism known as hypertrophy. Complications. Heart failure. As the ventricle becomes stiffer, its ability to fill and pump blood efficiently is compromised. Arrhythmias. LVH disrupts the normal electrical pathways, increasing the risk of atrial fibrillation and other arrhythmias. Ischemia. The thickened ventricular wall may outgrow its blood supply, leading to myocardial ischemia and angina. A 45-year-old man presents with fever, night sweats, and a productive cough. A chest X-ray shows cavitary lesions in the upper lobes of the lungs. A sputum culture is positive for Mycobacterium tuberculosis. What is the standard treatment regimen for tuberculosis, and what are the potential adverse effects of these medications? Answer. The standard treatment for active tuberculosis (TB) includes a 4-drug regimen known as RIPE, a rifampin-RIF. Inhibits RNA synthesis by targeting bacterial RNA polymerase. Adverse effects. Hepatotoxicity, orange-colored body fluids. Isoniazid inhibits mycolic acid synthesis essential for the mycobacterial cell wall. Adverse effects. Hepatotoxicity, peripheral neuropathy, prevented with pyridoxine. Pyrazinamide (PZA) disrupts mycobacterial cell membrane metabolism. Adverse effects. Hepatotoxicity, hyperuricemia leading to gout. Ethambutol inhibits arabinosyl transferase, disrupting the mycobacterial cell wall. Adverse effects. Optic neuritis, causing decreased visual acuity and red-green color blindness. This regimen is typically administered for 6 months, with the first 2 months intensive phase involving all 4 drugs, followed by 4 months of rifampin and isoniazid continuation phase. Explain the principle of herd immunity in the context of vaccination programs and describe how it can impact the control of infectious diseases within a community. Answer. Herd immunity occurs when a significant proportion of a population becomes immune to an infectious disease, either through vaccination or previous infections. This immunity reduces the overall amount of the pathogen available to spread, thus protecting individuals who are not immune, e.g., those unable to be vaccinated due to medical conditions. Impact on disease control. Reduction in transmission. When a high percentage of the population is immune, the transmission pathways are disrupted, making it less likely for non-immune individuals to come into contact with the pathogen. Protection for vulnerable populations. Individuals who cannot be vaccinated, such as infants, the elderly, or those with compromised immune systems, benefit from reduced exposure to the disease. Outbreak prevention. High vaccination coverage can prevent outbreaks of vaccine-preventable diseases, e.g., measles, polio, which can have serious health consequences. The threshold for achieving herd immunity varies by disease and is critical for the effectiveness of public health vaccination programs. Describe the mechanisms by which Staphylococcus aureus evades the host immune response and outline the implications of these mechanisms for treatment. Answer. Staphylococcus aureus employs several mechanisms to evade the host immune response. Capsule formation. The polysaccharide capsule inhibits phagocytosis by preventing immune cells from effectively engulfing the bacteria. Protein A. This surface protein binds to the Fc region of immunoglobulin G, preventing opsonization and thus hindering effective immune response. Coagulase production. S. Aureus produces coagulase, which converts fibrinogen to fibrin, forming a protective clot around the bacteria, shielding it from immune cells. Toxin production. Various toxins, such as alpha-toxin and leukocidin, can damage host cells and suppress immune responses. Implications for treatment. The ability of S. aureus to evade the immune system complicates treatment, often requiring high-dose antibiotics. Methicillin-resistant Staphylococcus aureus (MRSA) strains present additional challenges due to antibiotic resistance, necessitating the use of alternative therapies, e.g., vancomycin linezolid. Discuss the systemic inflammatory response syndrome (SIRS) and its criteria. How does SIRS contribute to the development of sepsis, and what are the clinical implications for management? Answer: Systemic inflammatory response syndrome (SIRS) is a clinical syndrome characterized by a systemic response to infection, injury, or inflammation. The criteria for diagnosing SIRS include fever, temperature 38 dec 100.4 dec or 90 beats per minute, respiratory rate, tachypnea 20 breaths per minute, or arterial code tension, POCO 12,000 cells, leukopenia, 10% immature forms, band forms. When SIRS is triggered by an infection, it can progress to sepsis if there is evidence of infection and organ dysfunction. The pathophysiological mechanisms involve exaggerated immune response, release of pro-inflammatory cytokines e.g. TNF-alpha, IL-6 leads to widespread inflammation and vasodilation. Microvascular injury, increased vascular permeability results in fluid leakage, contributing to hypotension and organ hypoperfusion. Metabolic dysregulation, increased metabolic demand and altered cellular metabolism lead to cellular injury and organ dysfunction. Clinical implications: early identification and treatment of SIRS are crucial to prevent progression to sepsis. This includes prompt antibiotic therapy, fluid resuscitation, and monitoring for organ dysfunction. Sepsis management often requires a multifaceted approach, including vasopressors for hypotension and supportive care for organ function. Understanding SIRS and its implications helps clinicians recognize high-risk patients and initiate timely interventions. Describe the structure of a typical enveloped virus and explain how this structure affects its mode of transmission and susceptibility to antiviral agents. Answer: an enveloped virus has a lipid bilayer membrane surrounding its nucleocapsid, which contains the viral genome and associated proteins. Key features include lipid bilayer, derived from the host cell membrane. It contains viral glycoproteins that facilitate entry into a host cell's nucleocapsid. Consists of viral RNA or DNA encased in protein, providing stability and protection. Effects on transmission and susceptibility. Transmission: enveloped viruses, e.g. influenza, HIV, are typically spread through direct contact, respiratory droplets, or bodily fluids due to their sensitivity to environmental factors. Susceptibility: the lipid bilayer makes them sensitive to desiccation, heat, and detergents, making hand sanitizers and disinfectants effective. However, this can also limit their survival outside the host.